Have you ever looked at an X-ray and wondered why some areas shine bright white while others appear dark and shadowy? Let's unravel the story of two key players, radiopaque and radiolucent. These two properties are your guide to interpreting IOPs like a pro. Radiopaque materials are the heroes that block X-rays. They don't let X-rays pass through, and that's why they appear bright white or light gray on the radiograph. Real-world examples appear on the IOPA, highlighted one by one. On an IOPA, radiopaque areas include the enamel and dentin, which are highly mineralized, metal restorations like crowns or fillings, which are even denser, the jawbone showing the structure that holds the teeth in place. Now meet radiolucent materials, the ones that allow X-rays to pass through effortlessly. These areas appear dark or black on an IOPA. Radiolucent areas represent the pulp chamber where the nerve and blood vessels reside, caries which shows demineralicy area of hard or radiopaque surface. The periodontal ligament space, a thin, dark line around the tooth roots. Any abnormal spaces like a periapical abscess or a cysta, the magic happens when these two contrasts combine. A healthy tooth has bright radiopaque enamel and dentin protecting the dark radiolucent pulp chamber. But what happens when there's a problem? For example, in dental caries, radiolucent shadows invade the enamel and dentin, indicating mineral loss. Or in the case of a periapical lesion, you might see a dark radiolucent area at the root tip due to infection or bone loss. Here are a few tips for interpreting periapical radiographs. Identify radiopaque landmarks like enamel, restorations in bone. Look for radiolucent abnormalities such as caries or lesions. Understanding radiopaque and radiolucent areas is like learning a new language for dental diagnosis. The bright whites and deep blacks tell a story. We will let you know who you can learn language. Let's break down the radiographic lineup of your teeth. No need for a magnifying glass, just a good oral X-ray. First, we have enamel, the overachiever of the bunch. At about 95% mineral, enamel is the most radiopaque substance in your body. On an X-ray, it's like the V-up section, bright, shiny, and impossible to miss. It's doing its best to protect your tooth, so give it some credit. Next up, dentin. With 75% mineral content, dentin's not quite as showy as enamel, but it still pulls its weight. It shows up on radiographs as a middle ground, somewhere between the bright white of enamel and the dark shadows of other structures. Then there's cementum, the unsung hero. Its radiopacity is similar to dentin, but it's so thin that it's often overlooked in radiographs. It's like the quiet team member who gets the job done but doesn't need the recognition. Lastly, we have the periodontal ligament. It's the Houdini of dental tissues, radiolucent, meaning it practically disappears on X-rays. This collagen-rich structure is hard to spot, but it's there, doing its important job of keeping your teeth in place. Let's talk about the lamina dura, a thin radiopaque ring of dense bone that forms the tooth socket. Think of it like a protective thimble around each tooth, ensuring it stays in place. But much like any good thimble, its visibility on an X-ray depends on how thick the lamina dura is when the X-ray beam passes through it. More thickness, more opacity, simple as that. This layer is continuous with the shadow of the cortical bone at the alveolar crest, giving us a consistent outline of bone on a radiograph. But don't be fooled. The lamina dura is only slightly thicker than the trabecula of the surrounding cancellous bone. It's not some mystical extra mineralized tissue. It's just cleverly positioned to catch the X-ray beam at an angle, creating that eggshell effect where it shows up more clearly than you'd expect it. Here's where things get interesting. The thickness and density of the lamina dura vary with the amount of occlusal stress or how much your teeth are working for you. Around teeth that bear heavy occlusal stress, like molars, the lamina dura is thicker and denser. Around those teeth that just sit there and don't do much, it's thinner and less dense. It's like the lamina dura is the bodyguard of your teeth, getting tougher when things get tough and slacking off when it's not needed. But wait, there's more. If you notice a double lamina dura, it's usually because there's more than one elevation in the root's path that the X-ray passes through. A classic example is on the buccal and lingual eminences on the mesial surface of the mandibular first molar. Don't worry, it's not a double booking, it's just the X-ray showing off a bit. Why should we care about the lamina dura? Well, its appearance is a key diagnostic feature. An intact lamina dura around the apex of a tooth. That's a good sign. It suggests the pulp is still alive and kicking, but let's not get too carried away. The absence of a lamina dura around the apex isn't always a red flag. Sometimes it's totally normal. For example, you may not see it around molars extending into the maxillary sinus, and that's just how it is. In the end, remember, the lamina dura is like that dependable friend who's always there when you need them, but they don't always make an appearance. Now let's talk about the alveolar crest, the gingival margin of the alveolar process that sits between your teeth. On radiographs, this appears as a radiopaque line, almost like a delicate bone bridge between the teeth, and it's called the alveolar crest. Think of it as the little fence between your teeth holding them in place. So how do we know if the alveolar crest is behaving itself? Well, in an ideal world, it should be no more than 1.5 m below the cement enamel junction. That's the meeting point where your tooth's enamel and the root cementum shake hands. Over time, with age or show-marked resorption with periodontal disease, the alveolar crest can recede like a slow-motion game of hide-and-seek. Figuring out what the position actually means is a clinical issue, so we have to rely on our skills in the exam room. In the anterior region, the crest is pretty minimal, just a little point of bone between the close set incisors. It's like the tooth's version of a minimalist art installation. But in the posterior region, the crest is more flat and aligned, parallel to the cement enamel junctions of the adjacent teeth, just hanging out below them like a well-placed shelf. And here's the important part. The alveolar crest is continuous with the lamina dura, and they meet at a sharp angle. If these sharp junctions start to round off, that's a red flag. It's often an indicator of periodontal disease, so we need to pay attention to those subtle changes. Let's now turn our attention to the periodontal ligament, or poddle for short. This little space, primarily made of collagen, appears as a radiolucent gap between the tooth root and the lamina dura. Picture it like a cushion that surrounds the tooth, starting at the alveolar crest, wrapping around the root, and then back up to the crest on the other side. It's like the tooth's own personal shock absorber. Typically, the PDL is thinner in the middle of the root and a little wider near the alveolar crest and the root apex. This suggests that the sweet spot or the fulcrum of physiologic movement for the tooth's movement is right where the ligament is thinnest, kind of like finding the most flexible spot for a dance movie.